Ben Nash. I'm currently 46. I'll tell you a little bit about myself and where I've been and what I'm doing now. But before I begin, who all is involved with medicine or has an interest in going into medicine, either as a doctor or nurse or pretty much, okay, good deal. Who isn't going into medicine? What's your interest?
Nutrition.
Okay, what's your interest?
Biotechnology.
Technology? Okay, like medical technology or something?
Biotechnology.
Okay, all right. Anybody else? Did I miss somebody that doesn't want to be called on? Well, I'm 46. Been, like Rich said, I started out in a completely unrelated field. Went to college, got my degree, got out of college, had trouble finding a job in the area that I was interested in. So I started looking into just normal heating and cooling. So I wound up doing residential heating and cooling installation for about 14 years. My wife was a nurse. In about 2008, we hit a recession, or well, they call it recession, and kind of a decline where, kind of like we're doing now, interest rates were going up really high. People weren't interested in spending money. I got laid off for about 6 months. During that 6 months, my wife kept getting calls from the hospital. Can you come in? Can you please come take extra shifts? And I was like, you know what? They're asking her to work and I'm laid off. I want to work. So I'm like, okay, fine, enough. Career change. Went to evening classes because I did not have any of the science background for nursing or medicine or anything like that. Did that for a couple years. Went to nursing school in Quincy. Graduated with my RN, my bachelor's in nursing. Worked in an ICU for about 5 years in Quincy, and then my interest actually was anesthesia, which is kind of why I went into nursing. And after 5 years, it was do or die, so I decided to apply. And it's very difficult to get in. If you have been looking, it's very difficult to get into different medical related fields. Anesthesia is one of them. Many of you, if you have an idea of where you want to go for medical school, it's good to start applying now or letting them know you're interested. Many times you'll apply at more than one place. You'll apply to 1 or 2 or 3 or 4. I was very fortunate. When I applied, I was not lazy, but in a pinch. So I applied to one school, got an interview, got through the interview, got accepted, and I just went there. So sometimes it works like that. You'll apply to one place, you'll get the interview, you'll go on through, and it'll work out. Other times, it won't. The guy sitting next to me, he's like, well, what's the worst thing that could happen here in this interview? And I'm like, the worst thing that can happen is they say yes, come on. Because then you just totally flip your life around. And I was stable. I had a stable job, stable income. And then I went to school and all that went away. And then I started living on borrowed money, kind of like some of you are here now. And then that comes due and then you have to start paying it back. But I was fortunate, I got accepted. I spent 3 years at Southern Illinois University at Edwardsville, going through their anesthesia program down there. So I'm a certified registered nurse anesthetist, which is a mouthful, but most of the time it's just CRNA. And I go by Ben. That is a doctoral program that I went through though, so okay. I'm actually a doctor. Okay. My wife is a doctor, how you doing? I'm a doctor nurse, she's a doctor nurse. So we usually don't use the doctor prefix when you're a registered nurse or certified registered nurse in the medical field. For instance, in the hospital. Now outside of the hospital setting, I use my prefix doctor all the time. Well, not really all the time, but because I don't use it there much. But it's confusing for the patient. So you come in, you're sick, you have a broken leg, you have an appendix that needs to come out. I come in, I'm Dr. Nash, but I'm a nurse. Whereas a medical doctor comes in and they're a doctor, whoever. So in order to avoid the confusion, I personally don't use it. Now I have colleagues that do, but I'm a nurse. I'm a registered nurse, I do anesthesia. Hi, I work with Dr. So-and-so, I'm here to provide your anesthesia. So we put people to sleep, wake them up, do nerve blocks, pretty much anything you can think of. When you go in the hospital and you go under, that's my job. I put you under, you're under for the surgery, and then I wake you up. If you're in with a baby and you're gonna have a C-section, we'll do usually a nerve block and try to block the nerves that are gonna be associated with your C-section and provide comfortable delivery. So in a nutshell, I went to college, got a degree, went into heating and cooling for about 12 to 14 years, got out of that, got another degree, which is another bachelor's, and then I got another degree, and I'm done with degrees by now. I'm no more, I'm done. Now I will continue education in the field that I'm in, because anesthesia is always changing. especially with nerve blocks. And a lot of you have heard about fentanyl and opioid crisis and different things associated with that. Regional blocks, where we use anesthesia and we inject it around different nerve bundles to block the feeling. So if you've been to the dentist and they've numbed you up, that's kind of what we do, except we do it all over your body, anywhere that you might need it. Knees and hips, spinals are common, epidurals for delivery. So if a woman is giving birth to a baby, you give her an epidural, helps kind of bring that pain down to where it's tolerable, she can deliver the baby and how she goes. All of that is kind of an advancing field. So that's one of the things where I have continuing education, where I have to keep up with different local anesthetics, how they work, how long they work, how do you do it safely. There's different places that you can go for about a week or two to get kind of a specialized, but I've already covered most of that in my schooling. It's just more of a specialized review. There's also different certifications that I have to keep up. One of them is my anesthesia certification. One of them is basic life support. So if any of you have been swimming and the lifeguard is there, they have to have basic life support. Most of the time they don't do advanced life support, but they can. So BLS, ACLS, and then pediatric life support is another thing that I have to keep up, keep current. I work in Illinois. There's a difference in a medical doctor who is an anesthesiologist and my profession, which is a certified registered nurse anesthetist. In Illinois, the anesthesiologist, or MDA is what we call them, can have 1 MDA to 4 rooms or 4 CRNAs. So I have an oversight in my position in Illinois. Now, if I go to Iowa or any place out west where the population is diminished, I will assume the role of a MDA, and I will be expected to perform in that role as an MDA. So everything they expect a medical doctor of anesthesia to do, they will expect me to do in Iowa or pretty much any western state until you get to California. So Illinois is the seat of the medical association, the American Medical Association, and so they have a lot of say in how things go, and that's fine. They've been here forever. All the MDAs I work with, I get along with very well. We're usually on the same page. We consider each other colleagues. They'll ask me, what are you comfortable doing? What do you think we should do here? I'll do the same to them. I'll come up and say, hey, I've got this, what do you think? So it's very collegiate. We have a lot of good communication between my profession or my role and their role. If I say I'm uncomfortable doing this, or I see something in this patient that we need to look at, they're very good about saying, let's look at it then. Because it's, the last thing you want to do is to put someone to sleep and they never wake up again, or they don't wake up the same. So everyone is very respectful of the patient and each other. I enjoy what I do. I enjoy where I am. I'm very thankful that I chose the path that I took. I was 40 when I got accepted to anesthesia school, which is late. Most of the time they won't take people that age. The cutoff's probably around 45 or 46. And the understanding is it's a 3-year program. So if you go into it at 46, and you can get accepted at 46, you just have to persevere. You have to keep going. So instead of applying to 4 different schools, you're going to apply to 8, and you're going to keep applying until somebody says yes. So don't let the age worry you, which none of you in this room have to worry about that right now. But if you have a career change later on, and you're saying, listen, I don't want to do this, I want to do something different, don't let the fact that age starts to limit you. Just keep pursuing it. So eventually someone will say, yes, we'll take you. But the idea behind it is it's a 3-year program for nurse anesthetist. If you're in the medical profession as a doctor and you're going through, it's going to be even longer. As a doctor, medical doctor, you're going to do everything that you have to do, kind of like I did my prereqs in nursing school and I did my 5 years in ICU. You're going to do all the prereqs for the medical school. You're going to go through medical school. You're going to have a residency. And then you're going to have a specialty or a fellowship or a focus, like anesthesia or ortho or whatever. So medical school is going to take you 8 to 12 years, and that's just kind of common. And don't be disappointed by that. I mean, that's what you want to do, then pursue it, go after it, and go get it. I took about the same amount of time, but I did it chopped up. I went to here and I went to here, and then I did my ICU experience, and then I finally got into anesthesia. And I'm very happy where I am. I don't like school. I don't like the way it's set up, especially for nursing. I'm a guy, and they don't tailor the guys necessarily. I feel like ladies have a little bit easier time of it because I'm a minority in nursing. Most of the nurses are female, very few guys. Now that's changing. There are more guys going into nursing, and that's okay. That's fine. But there is a thought process that's a little different, and it takes some getting used to, and I don't enjoy that. So, but I got through okay, and it just, you have to find help. If you're struggling, you ask. Medical school is a little bit different. They like to help people get through. So if you're struggling, they're very good at helping you find your areas of weakness and finding tutors or finding people that will help you get through. So, and that's just the way it's set up. That's life and death of it. That's kind of the way it is. So, but that's my story. I've been working as a nurse anesthetist now for 3 years, and I still love it. I really enjoy what I do. I don't like school, but I love what I do. And you can find a lot of people like that. You know, they like this part of it, they don't like that part of it. But don't let that stop you. If you don't like one aspect of it, just put your head down and work hard and get through it. And if you can put it behind you, so much the better. You may revisit it at some point, but. Does anybody have any questions about,
Yeah, so I imagine when you decided, when you're like, all right, we're gonna pick up this nursing thing, and you first started going to classes, I imagine picking up from not being in school for so long, how difficult was that transition?
There was a little bit of a learning curve there, but a lot of the sciences that I didn't take, I really enjoyed. So enjoying them makes them less tedious and easier to learn. So the night classes that I went through to catch up, to get all my science courses out of the way, biology and all that stuff, micro, for the most part I enjoyed all of it, for the most part. Nursing school, I did not enjoy, but I did do well in after I figured out how they ask their questions. It's a different thought process, and what really helped me, and I would encourage you to do it too, medical schools will have it as well, find, they have different, it's not a study guide, but it's like a book full of questions, and there's different names for them, different companies put them out, and I found that when I was struggling in an area, I would get this test book. It's one you can buy legally at the bookstore or wherever, you can order them. I would just find that area that I was struggling in and do 200 questions, 300 questions, and they give you a rationale as to why the answer you got was right or wrong. And I found that really helped me narrow my focus, because in nursing or in medicine, pharmacology, whatever you're going into, there is so much information they can't cover it all. So they're gonna cover what is important, what's on the test, and then they're gonna hand you a stack of books and say, we're gonna cover 6 chapters by next weekend. And then the weekend after that, you're gonna have a test on it. So there is a massive amount of information that you're gonna be exposed to, that you're gonna be expected to kind of be responsible for. And the testing guides really help you narrow your focus, and they don't teach towards the test, but they help you kind of figure out what they're asking, what probably will be on the test.
Right.
Because every medical profession, whether it's what I'm in, nursing, anesthesia, any medical doctor, any pharmacology, there's a board, a state board that governs your profession. And in order to be approved to work in that profession, you will have to pass a state board test. So there is a standardized test that once you pass it, you'll be able to work in your profession. You'll be certified, like I'm a certified nurse anesthetist. But you'll have to study to pass that board, and that is a national board. It's not just the state of Illinois. Every state has a board that covers their certification. So you figure out kind of what they're asking, you can narrow your focus, and you can really drill down on what you're really struggling with. Some things will come easy, some things won't. And what you're struggling in will show you your weakness. And there's a lot more. When I went through CRNA school now, it's all online. You can buy, for me it was Prodigy and Apex were the anesthesia ones, and you can tailor what you're struggling in, and it will give you 2,000 questions if you want to take that many at one time. Or you can chunk them off in like 150, and then every day you're doing like 150 questions in an area. But I'm sure there will be similar programs that you can do online that will help you with that. Any other questions? Yes?
This is kind of a difficult question, but what's one piece of information you wish you knew before going into nursing school?
Oh, that is a good question. and that is difficult. My experience is different than most of yours because I went in late. I was married. I had 3 kids at that time. So I was I was not your typical student. It's the hardest thing I've ever done. Going to school with a family is extremely difficult. I would encourage all of you, or any of you, if you don't have kids yet, please try to wait till you're done with school before you have them. But sometimes life happens, and when life happens, you just roll with the punches. What I wish I knew before I had started, so I had goals. One is providing for my family, one is to be altruistic. I feel good in my job that I'm helping people. So when somebody is gonna have below the knee amputation, so for whatever reason their foot is not healthy and so they're gonna cut their leg off below the knee, I feel really good about going in there and being able to provide a block, first of all, to that leg, and then get them to sleep. If you provide a regional block to the leg, the studies have shown that once that leg is removed, there's a lot less phantom pain. So it really helps them in the long term if you can block, like I said, the locals that you're doing a nerve block with. And I love that. I love feeling like I'm helping people, like I'm contributing to something that is unavoidable for them, but I feel like I can maybe help ease what's going on. What I wish I knew is that you can't help everybody, and some people don't want your help, and there are days when it's not fulfilling, but ultimately I still am happy with what I'm doing and providing what I perceive to be a benefit to others. ICU was good for me. It was part of my experience. In ICU, first of all, it was a requirement for anesthesia. You have to go to a critical care area. So whether it's cardiac or ICU or a pediatric ICU, which I did not want to work in. I have kids, I sympathize too much with little kids. Now I do procedures on little kids or help, but it's hard for me to do so because I'm very empathetic. I don't want some little kid, unfortunately, to die under my care. It's not something that so I avoid pediatrics as much as I can. But in ICU, you learn that you don't really have control over the patient's condition. You can do everything right, and you can do everything in a timely manner, and they will still die. In ICU, we had patients that would come in, and you think, oh my word, this person was in a huge wreck, and they're not responsive, and their pupils are fixed and dilated, which is a bad sign. You go off shift, and you're like, well, by the time I get back, that person's gonna be gone. I know it. And you come back on shift, and they're still there. And a week later, they're still there. And a week later, they wake up, and you're like, it was nothing I did. I mean, it was, Then you'll have somebody come in, and they're talking to you, they're sitting up, they're getting better, they're gonna get out of ICU, and you're like, all right, I'll see you tomorrow. And you come back tomorrow, and the room's empty. And you're like, oh, hey, did so-and-so go out to the floor? And I'm like, no, they died. And you're like, seriously? So you learn that you do the best that you can. And you do what you can to help people, but ultimately their fate, it's not in your hands. So there's a little bit of freedom in that where you do the best you can, especially in anesthesia, and you don't want poor outcomes or bad outcomes, but you're not ultimately in control of everything. You do your absolute best to make sure they're safe. You do your absolute best to follow what the best procedure, what the best standard is for this, but sometimes the result is not what you want. Yes.
What is the most challenging experience you've had so far in your job?
Oh, that's a good question. Because there are many aspects of it. There's a lot of interpersonal relationships in the OR and in medicine. You're going to be dealing with patients, first of all, and some patients are great and some are not. And some people, so smoking, I'll pick on smoking. I don't know who smokes and who doesn't, and I don't care. But smoking is one of those things that's been proven to reduce your healing times. And as you age, so if you're all young, your healing times are great, I'm sure. But when you hit your 60s and 70s and you've been smoking all your life and you're not gonna quit, and you come in and you have your below the knee amputation because you're diabetic and you have to take care of yourself and you smoke, and that doesn't heal. Your vasculature doesn't heal because you're smoking, and smoking has been proven to slow all these healing times, and as you age, So one of the things I struggle with is, you know what's best, you know what's best practice, but people don't always follow it. Now that's not the hardest thing. You know, the hardest thing is probably traumas that come in at this point, where you're doing your absolute best to save whoever, whatever accident they had. They tripped going through their garage, fell on a step, and they landed on their spleen. So now their spleen is ruptured and they're bleeding out. And it's not blood you can see. So you're doing everything you can to save them, rapid infuser, blood products, IV fluids, everything, trying to get them to the surgeon so the surgeon can open them up quick and clamp everything and get the spleen out of there. And struggling to do the right thing in a short amount of time probably is the biggest thing. Like, you have so many demands on you that you're trying to process everything as quickly as you can, to do the right thing as quickly as you can, to try to save the patient and to do the absolute best you can for them. And some of them you can and some you can't. Some you can't. 21-year-old, I won't tell you the gender, celebrating a birthday, coming back to visit family, was out of state, drinking with friends, coming back into the state to visit other family, driving, rolled the car, got ejected, life flighted to Blessing. My job was to take care of this person. And they had a basilar skull fracture because they got ejected. They weren't wearing their seatbelt, which basilar skull fracture is right here at the base of your neck. And basically it's a hangman's fracture is what it is. Their head just got pulled off of their neck and the bleeding. And so you're transfusing blood and fluids and doing everything you can for this young person who has their whole life ahead of them. And you can't save them. There's nothing you can do. There's no surgery that you can do to repair that fracture. There's nothing that you just basically keep them alive and do everything you possibly can to keep them alive as long as you can, and then they die. And then family comes in, and understandably on this person's birthday, and you're doing everything you can to save them, and then you have to sit down with family and explain to them why it didn't work. The other difficult thing is, and I saw it way too many times, when your parents get older, or if you have them, if you may not have parents, but if you do have parents and they get older and they start getting sicker, most everybody wants to do the best they can by their parents. So they have their parents be a full code. They have their parents, I want every measure taken to preserve their life, to do whatever we can. And at a certain point, your body gives up on you. It's done. You've run it as hard as you can, as long as you can, and your body's not going any further. Then you run into issues, and it's an ethical and a moral issue, where you're giving life-saving support to someone who is dying. And if they're just hanging on, sometimes you can get them back 4 or 5 or 6 times, but then you're coding them 4 or 5. If you code someone, my heart stops, I fall to the ground, you're gonna call 911, flip me over, check to see if I have heart rate. Hopefully there's an AED around here somewhere that you can put patches on me and it'll tell you kind of what to do. But you're gonna start chest compressions at some point, someone will. And when you do chest compressions appropriately, you break ribs, usually right next to the sternum, sometimes on the sides. If you're doing it on an 86-year-old lady, you're gonna break every single rib and possibly the sternum because they're osteoporotic, their bones are thin and brittle, and you're doing chest compressions. So you're gonna do that 5 or 6, 7 times because the family wants everything done, and you're basically brutalizing this poor person who should have been gone a month ago or weeks ago. And it's hard as a medical provider to go in and maybe you won't get them back, maybe you do, you know, and then have them come to, and I had it happen to me, this poor older person, this is the first time I thought of it, and it was at the beginning of my medical profession, looked at me and said, "Why are you torturing me?" And I had to stop and think, and I'm like, well, good night, we saved this person like 6 times, but they're not wrong. You know, we're essentially torturing this person every time. And there's complications that come with CPR. You know, you don't breathe as deeply because it hurts. You have broken bones, you can get pneumonia. I mean, there's all kinds of things. So you really have to weigh checks and balances of, am I helping this person, or am I really prolonging the inevitable, and am I actually hurting them? I'm helping, but am I really helping? And that's one of the things that's probably, answer to your question, the hardest thing, that's probably the hardest thing. What am I doing that is actually helping this person or hurting this person? And I am not for, and this is my personal opinion, this is not part of the medical field, this is me, Ben, saying this. I am not for assisted suicide, and some of you may be, and that is your opinion, and that's your choice, and that's fine. I'm not here to argue that. But morally, I'm not for assisted suicide. But then you ask me, okay, well, what about someone who has terminal cancer, and they're on hospice, and they're not gonna get better? And then I go, well, yeah. So I'm not for assisted suicide, and I'm not for legalizing marijuana. And I'm sure that's probably gonna shock a ton of you. And let me tell you why. I mean, first of all, it's a personal reason, but second, marijuana stays in your system if you're in a medical profession, and I am helping someone and they die under my care. So they think, well, that was strange. So they test my blood and I'm positive for THC. Then they can come back on me and say, well, you were under the influence. Well, I had that 4 days ago. Well, that doesn't matter. So if you're going into the medical profession, you really need to think about how you use marijuana and if you should. Again, I'm not saying you shouldn't, but I'm saying you should at least consider, how do my actions and what do I take into my body affect who I'm taking care of? And I could possibly be out of a job and out of the profession if I get sued because this person died under my care through no fault of my own, but I am positive for THC. So that's another thing. Back to, I'm not a fan of marijuana. Again, you have someone on hospice. They have cancer, they have bone cancer. It's extremely painful, it's excruciatingly painful. So we give them opioids. Opioids knock them out. They can't talk to anybody, they sleep all the time, they're not in pain, but they're also not communicating. So do we use an edible? Their pains are more under control, they're talking to their loved ones while they're on hospice and dying. So you have to think about different things about how you use them. Is that something beneficial? Well, yeah, it really could be. I could see how marijuana could be beneficial to someone who's dying from cancer, very much so, to the point that I might even prescribe it if I had that option. It's just something to think about. So no, I'm not for marijuana, but would I prescribe it to someone under the right circumstances? Absolutely. I mean, how is that any different from an opioid? How is that any different from fentanyl that I give every single day? How is it any different from remifentanil, which is about 1,000 times stronger than fentanyl that I give every week? I do it under certain circumstances to help someone's pain, to help them not feel anything during the surgery, and then they recover, and then they go on to something else. And at what point are you going to use opioid? I think having your abdomen cut open and your kidney or your appendix or your gallbladder being taken out is a very good justification for using fentanyl or remifentanil or something that just you don't feel the pain and you don't remember it. I think that's a wonderful thing. So I think we can use other drugs in a similar manner, but I think it needs to be very, very thoughtfully considered. And that's, again, my opinion. I can show you different things to back it up, but again, there are about just as many studies that say opposite. So that's my opinion as a medical provider. Yes?
Do a lot of nurse and sorry, I can't really.
No, you're fine. Anesthetists, yeah. CRNAs.
Do they work a lot at hospice care?
No. So with hospice, and that's one of the reasons why I use hospice, I don't prescribe anything for hospice. Hospice care is a specialty all of its own. There are nurses that do work hospice care. There are nurse anesthetists or MDAs that do pain clinics, and they will use, not marijuana, but they'll use different legalized drugs to help with pain control. So you may have like chronic back pain, so you're gonna go to a pain clinic and they're gonna assess everything and they're gonna maybe give you opioids or a certain combination. Suboxone is one of the ones that they prescribe. It's a little bit hard to overdose on that because it's up and a down at the same time. So it controls kind of what you're taking. It's hard to overdose on it, but it's also addictive. People get addicted to it, especially over long-term pain control. So there are instances where a CRNA or an MDA would be considering different methods of pain control at a pain clinic, but that's not hospice. Hospice is specific to someone who is not going to survive. Usually it's like 8 weeks, 12 weeks, something like that they put them on hospice. And their lifespan is usually shorter than the predicted 8 to 12 weeks. So, and then so my mother-in-law, I'll give you an example of hospice. My mother-in-law had neurodegenerative cancer in her spinal column. It was a certain kind of neurocancer, I don't even remember what it was called, but a specialty. She had to send samples up to Mayo's, and they tested it and said, yes, it's this certain type of neurocancer in her spine. So her discs were collapsing, she had a lot of pain. One of the things that helped her, she had radiation done at the site, and it more or less burned the nerve endings right there. So she was no longer in pain, but then she would know, she'd try to take a step and just kind of, there's no support there because the nerve endings are gone. So that continued for about a year. We got her home around Thanksgiving, put her on hospice right after Thanksgiving, which I have nothing but good things to say about hospice. They came to her house, set up a hospital bed in the living room, set up an oxygen tank in the living room. We had our meal at home with her. Now she's kind of out of it because at that point she was prescribed morphine for other pain. So we would give her morphine, and you had a certain amount that you could give. You could give it around the clock, and the nurse would come dispense that, or a family member could as well. She passed away before Christmas, and I can't say enough. I mean, we had time with her at home. She wasn't in a hospital, she wasn't in a nursing home. It was something that, we could have family over and we could. So hospice is a very specialized profession, and there are very special people that do that, much like there are special people that take care of children. I'm not one of those. I mean, I will if I have to, but burns. Burns are something that are very, very tough. I do not specialize in burns, although I will provide anesthesia for them. That's not something that I want to do either. I did do that during my clinicals for my profession. I don't know that there's enough pain medicine to help someone who, Jay Leno just burned himself on his car. So he went to a burn unit and came out looking really good. Looks like he's gonna have a full recovery, which is great for him. But burns are very, very difficult. They're a long process, and it usually involves going in and scrubbing skin that has been burned. So you can imagine, here you are burned, and there's a char, and after so long they take them to surgery and they peel that char off, and then they have to scrub, and it's just excruciating for patients. And that takes a special person to do that, and I'm very thankful that there are people that do that. Again, I'm not really one of them. I will if I have to, but it's a wonderful thing that we have people like that. So, but yeah, that's where pain control comes in a lot too with burns.
So you talked about before, how was your kind of like your mindset changed once you got into nursing school? Like you said, maybe being the minority, just like maybe how you had to like flip a switch in your mind to focus a different way.
Yes and no. In some ways it's good to be a minority in the nursing profession where you're a guy and there's a lot of girls. You better get used to being asked for help a lot. And it's mostly just because of lifting. So you have patients you have to move and turn and everything. And when you have I'm not 6 foot, but let's say I was 6 foot. You have a 6 foot guy on your floor who's fairly young, and then you have all these little ladies, and they're very competent. You're gonna get asked for help a lot to turn patients, especially when your patients keep getting bigger. So you're looking at like a 350-pound patient or a 400-pound patient, and they have a bed sore. So you've gotta open that wound up, and you've gotta strip out the packing, and you've gotta repack it. Bed sores that'll be this side, and you can put your fist in it. You'll be packing those, and you have to pack them every so often, every probably 4 hours or 6 hours. There's a time where you have to do it. So you'll get asked a lot. So that part of it, I didn't mind. Again, I enjoy helping. I enjoy running around and doing that. Learning how to take a test and learning what they are asking was probably the biggest hurdle of getting through. And doing multiple questions, hundreds of questions or thousands of questions, help get you into that mindset where they'll ask something, and it's always multiple choice. They've changed it now. There's actually 4 different styles of questions they can ask you now. But anyway, practicing is always good, and that helps you get you in that mindset.
Did you feel like you were included, or did you feel kind of?
Yes,
Okay.
yes, I did. Yeah, I never felt left out at all, ever. It's kind of the one profession I can go into as a white middle-aged guy and be a minority. I mean, that's not common. That's usually not a thing. And like I said, that's changing. There are a lot more people going into nursing and the medical profession. Right now, we have a lot of people in the medical profession from overseas. Just pick a country, and people are coming. You know, we have doctors coming in. So there's always a shortage of nurses, medical providers, all of that. The doctorate position, medical doctor position, is being filled not with Americans, but with people coming over from other countries. And that's fine. I get along with almost all of them. Sometimes you have to ask them to repeat themselves. And they have different cultures and customs, and so you try to understand where they're coming from. And again, we haven't really had an issue. But that's one of the things, that's one of the big changes recently we've seen, is a lot of different, yeah.
So specifically when administering anesthesia or during a surgery, what are some common like medical issues that you have to troubleshoot?
Okay, that's a good question. A ton. So, I had a good one, if I could remember everything about it. So this patient had renal failure, was on hypotensive medication, had cataracts, had, oh my word, I wrote everything down, and I wish I could remember it all. But there were like 18 different things that were wrong with this individual. And if I could read all of them to you and then ask, what would you guess this person's age to be? You would probably say someone in their 60s, 70s, maybe even 80 years old. Then this patient was 15 and had a special condition. So this special condition caused all of these issues. So here I am with a young person who normally you treat as like a pediatric patient, or, and I hate to say that, but most of your early teenagers you're treating as a pediatric patient just because of their size or development. And this patient, I would have thought, oh, pediatric. No. You're treating this patient like an 80-year-old man or 80-year-old woman with all of the other things that are going on, and they're only 15. So there's a ton of different things you have to look at. If AFib, atrial fibrillation, when your heart isn't beating like it should, it's beating really fast, and it's not beating in time. And so you get this fibrillation. So you're not pumping blood like you should. You're still pumping blood, but it's not efficient. So your blood pressure's kind of off, and they'll pass out a lot, hit their head. New onset atrial fibrillation is a check mark. We usually, if we catch someone, and they've never had AFib before, and they have AFib, and they come in for surgery, we cancel the surgery. Just, nope, you're not doing it today. Because they need medical clearance through a cardiologist. So they're gonna need to go get their heart checked out. Why did they go into AFib? What's going on? If we induce them, which is giving them medication to make them go to sleep and then intubate or whatever, we can actually kill them if they have an underlying procedure or condition that we didn't catch. And the AFib was right there and it's saying, hey, I'm here, but we're like, we're just gonna go do it. So that's a big one. And that's a common one that I can just say, if you have new onset AFib, we're not gonna do your surgery that day. We might do it by the end of the week, or maybe a day or two later, but we're gonna send you to a cardiologist and they're gonna investigate and see what in the world is going on, why did this happen? Versus me going, oh, shit, now we need to, do our breaking ribs and stuff, yes.
How do you specifically deal with when a patient dies? How do you deal with the mentality of that, with coping wise?
That's a very, very good question. Not everybody dies the same. It's much easier to deal with the death of someone who has lived their life. So 92-year-old gentleman comes in and let's say he comes into ICU, he fell, hit his head, and he's got intracranial bleed, and so they've gone and tapped his skull and they put a drain in and they've sucked out the clot and he should be doing better, but all of a sudden he goes into a weird rhythm and dies in ICU. That's a lot easier to deal with because even though he has family coming in, they're mourning the loss of their grandpa or their father or uncle or whoever. They have lived their life. It's been hopefully a long and full life, hopefully a good life for them, versus a 21-year-old who got thrown from a car and you did everything you could and they died anyway, and now their mother's grabbing you by the front and saying, why couldn't you save my child? There's a lot of differences between the two. One of them, you go in and you talk to the family and you try to comfort them with a 90-year-old, and they're, well, you know, and you try to get them talking about their good memories. It's usually what I try to do. What do you remember? What's the best thing you remember about your loved one? And that usually starts a really good conversation. Oh yeah, remember when Grandpa did this, or remember when Dad did that? And it really helps them kind of express their emotion, and usually there's crying involved. When you have younger patients, children, and cultures affected as well, a variety of different cultures. There may be screaming involved, there may be yelling involved, there may be a lot of different things. So as a nurse or as a doctor, you're gonna wind up trying to stay in the moment and shoving all your emotions to the back. And that's, if you keep them there, that's not healthy. But you have to deal with what's in front of you at the time. And usually you have to like push all this back and say, okay, what can I do to calm this situation down? What can I do to help? What I found in ICU, because I had time to do it in ICU, is if someone was dying, I would call the chaplain. There's a blessing, there's always a chaplain that'll come and stand with the family and talk to them while their loved one is dying. The other thing I found beneficial was to have family present when we were doing CPR. Like, we're doing everything we can to save this person. We've got 6 people in the room, they're all doing something. To have family watch is very traumatic, but it also gives them closure, because you can code someone, we call the code, you know, you're coding this patient to try to keep them alive. You can code someone for over an hour. And let me tell you, you've never worked out until you've done chest compressions for almost an hour. You're rotating people through, you've got timelines where you're pushing different drugs, and the only way the drugs are gonna get moved around the body to do anything is if someone's pumping on the heart, you know, doing chest compressions. So for an hour, well, I sweat anyway, you know, whatever I'm doing, but you're just drenched. No matter who you are, you're drenched in sweat. And to have someone who may not understand what a code looks like, other than like Grey's Anatomy or whatever television show they've seen, which is not hardly ever correct, to have them watch a code and watching you do everything you can to save somebody's loved one usually gives them some closure. Usually they're saying, I want you to stop, please stop, just stop doing what you're doing and let them go. And that's fine too. But I feel like it's better for them to see that we have done every single thing that we can possibly do to save this person. And it really helps them to understand that, you know, nobody was just standing there saying, oh look, they're a little hard now, we probably can't do much. Versus like you're like running your tail off trying to save them. Yeah.
So you said you worked, like you did stuff in the OR, right?
Yes. Yeah, that's right.
So like, when you're doing a surgery, have you ever had like a patient wake up mid-surgery and like you...
That's a very good question. No, I have not, unless it was intentional. So, you've probably read stories or heard stories of people waking up under anesthesia. There are different types of drugs that we use to help with surgery. So, for instance, I'll give certain drugs to help people forget. It's called Versed. So, and it's kind of like you've been on a weekend bender. You can still talk to me, but you're not going to remember much. You know, it's kind of like you had the Kager and you're like talking to somebody, but you won't remember anything later on. That's what Versed is, and that helps. Most people don't want to remember going back to the OR, and I'll ask them, and if they say no, then that's fine. They can certainly go back without it. Once we get them to sleep, to put an endotracheal tube down, I will give them propofol, which many of you associate with Michael Jackson, who is using the drug off-label. Should never use it the way Michael Jackson used it, because what happened to him will more than likely happen to whoever's using it like that. I mean, that's kind of an expected thing. You get enough propofol, you go to sleep, and you stop breathing. So if no one's there to watch you and take over, I bag somebody. When they stop breathing, I start giving them breaths. That's normal. If no one's watching you sleep and you're on propofol, you eventually will get enough to stop breathing, and if no one's there, then you wind up like Michael Jackson. That's kind of the way it goes. So give them propofol, get them to sleep, tube them. I will also give them a paralytic. So this is kind of where this comes in, the question that you asked. A paralytic is exactly what it sounds like. It paralyzes you. You can't move, but you can still hear, and you can still think, and you still know what's going on around you, unless I've given you Versed and propofol. So if I only give you a paralytic, you cannot move, you cannot breathe, your heart still beats, your brain still functions, your blood pressure responds to pain. That's kind of how we monitor somebody that's, sorry, let me shut that off there.
Is that Superman theme music?
Yeah, I guess. So if I just give you a paralytic, you're going to know every single thing. You can hear and understand and know what's going on around you unless I give you other drugs. And anesthesia gases are, like the verse said, you won't remember much once you're inhaling those anesthesia gases. So there are stories of people who have woken up mid-surgery because either the gas ran out or the propofol ran out or something like that, and they can hear what's going on around them and they can feel what's going on, like the surgery, but they can't move. It's like a nightmare. Nobody ever wants that to happen. So when I said, yes, I have done that, there are exceptions. Brain surgery is one of them. So under certain types of brain surgery, they're going to want to see if you can respond. So they'll open up a part of the skull, cut the skull out, set it over here. They'll go in and they'll start working with tools. And you can look this one up because I wasn't involved with this case, but it typically shows you what you do. They had a violinist. He had tremors, and it wasn't Parkinson's. It was just a tremor. So they can go in, they can put a device in, and when you turn it on, it takes the tremors away. But the person can turn it off and on by themselves. And we had a nurse at Blessing that had that done. She had tremors too, and she could start an IV like nobody, but she had tremors and she had this procedure done. So anyway, this guy played a violin while they did brain surgery to see if his tremors would go away because he was a concert violinist, and you can look that story up. I mean, it's a fascinating read. But we have had cases in Quincy where, not anymore, our neurosurgeons are gone right now. But when we had neurosurgeons doing it, you would wake the patient up, they'd say, okay, lift your left hand. Give me a peace sign, squeeze. Can they follow commands? Can they move all extremities? And their skull's open, and they've got instruments in there. So that would be like an exception, where like you're getting a patient down, you're paralyzing them, then you're letting it either wear off or you reverse it so that they can follow command, like actually wake up and follow commands. We don't do that much. There are rare cases where that actually happens. And you never want them to wake up under a paralytic on their own. You want to have that reversed. First thing you reverse is the paralytic, and then you start weaning off the gases or whatever else is keeping them asleep. So they can start, when they start waking up, they can move.
Dr. Nash, do you have any good conclusions? We're running out of time. Maybe some people can ask questions at the very end but do you have anything maybe to kind of summarize or wrap up or a good?
Yeah, you're all going in the medical field. I changed my profession 3 times. I hope it works out for all of you. I hope you get to do what you want to do and you are successful in whatever endeavor you're pursuing, but don't be afraid of change. Sometimes things don't work out, and that's not the end of the world. Sometimes you have to change what you're doing in order to be successful, and that's okay too. So don't be discouraged if something isn't working out. You didn't get accepted by the medical school you wanted, you didn't get the grades you wanted on a certain topic, and that's going to limit where you go and what you do. Don't be discouraged by that. If you're interested in something, you keep pursuing it, and you may have to change it. You may have to change into something else, but keep going after what it is you're wanting to do. And that's what I did. So I'm just passing that on.
Could everybody give a round of applause for Dr. Nash? Thank you so much, sir.
You're welcome.
You did a great job.
Have a good afternoon, everybody.
Thank you.
Well,